interview with Professor Judson Brewer, a clinician and researcher focused on mindfulness, habit change, anxiety, cravings, and the neuroscience of behavior. In this conversation, he explains how work with patients struggling with addiction led him to study mindfulness as a rigorous clinical intervention, from smoking cessation trials to digital therapeutics for anxiety and overreacting. You can read more about Professor Brewer on our website, 6degrees.blog, or our Instagram page, 6 Degrees Away. Thank you and enjoy this video.
What single moment or patient experience first convinced you that mindfulness could be studied as a rigorous clinical intervention rather than just a personal practice?
That's a good question. It really started when I was working at the VA hospital in West Haven, Connecticut, and I was struggling helping my patients with addiction. And I remember working with some patients, and one in particular who came into my office and said, "Doc, I feel like my head's going to explode if I don't smoke." And that was a new chief complaint for me. But I walked him through a mindfulness practice. He didn't know anything about mindfulness. I didn't even mention the word, but I walked him through a practice which helped him see that his cigarette cravings were, in his body, that they come and go, and that he didn't have to smoke. And he had a big aha moment. And I guess for me, it was an aha moment as well, because I saw the power of bringing the present moment to people's experience and helping them use curiosity to ride out very strong cravings.
And so did this moment map a design, like a technique you still use today? I guess I'll rephrase my question. Did this first experience, did it teach you something that is parallel to techniques that people use today?
Yeah, it certainly turned into, so that was just an example of things that there are a lot of mindfulness practices out there. There are a lot that I'd been trained in. And so we actually packaged some of the ones that were most accessible to my patients into digital therapeutic programs. And we even started in person, and we did a randomized controlled trial in people who are trying to quit smoking. We got 5 times the quit rates of gold standard treatment. And so here we could test the specific techniques that were helping people, and then eventually package those into digital therapeutics and test them rigorously. And this led to results like 40% reduction in craving related eating. We got a 67% reduction in anxiety, and using these practices to help people work with their worry thoughts, and be able to relate to their feelings of anxiety differently than they had previously.
What's the most important thing we now know about the default mode network and habits from your lab's neuroimaging work, and why should a non-scientist care?
Yeah, that's an important so what question, which I think everybody should be asking. When we first started this work about 15 years ago, we were asking a simple question around, what's different in an experienced meditator's brain and a novice's brain. And so we did a study where we scanned people's brains as they were meditating, whether it was a novice that had just learned to meditate that day, or an experienced meditator who'd been meditating, on average around 10 years. And what we found, we looked very objectively. We looked across the entire brain and didn't go in with any assumptions. And what we found was that this default mode network was deactivated. And since then, we've replicated that study. Others have replicated that study. So it seemed to be a pretty consistent finding. And so what does the default mode network do? Well, it's a self-referential brain network, and it gets activated with a whole lot of different things, whether somebody is craving a cigarette, or somebody gets a bunch of likes on Instagram, or somebody is caught up in any type of addiction. Really, a lot of different type of addictive processes have been shown to activate the default mode network. Interestingly, it also gets activated the more somebody worries, the more some of these hubs of the default mode network get activated. And so it seems to correlate with getting caught up in experience. We've even done some neurophenomenologic studies to line up the subjective experience with the brain activity. So if you look at the theory of mindfulness, it seems to line up. It helps people notice when they're getting caught up in thinking about the past or the future, helps them notice when they're getting caught up in craving, and importantly, helps them not get stuck in those patterns. And so the so what question, or why should we care? Why should anybody care, whether they're a neuroscientist or a clinician or somebody that's working with cravings or anxiety is that, we've even done studies where we can prospectively predict how well people do with mindfulness training the more their brain activity changes in the default mode network as they go through mindfulness training. So it seems to be a brain mechanism that lines up pretty well with these practices, but also lines up with how we understand experience. The more we take things personally, basically, the more this network gets activated. And mindfulness training is geared toward helping people not take things personally. We can see that line up with changes in brain activity. So it seems to be a pretty good brain marker and also a good network that one might target, not just with mindfulness training, but eventually in conjunction with other modalities like neurostimulation or other therapeutic modalities that might help to augment those practices through stimulation or deactivation.
So assuming most people have some sort of habit loop, how does noticing mind wandering connect to a habit loop that people in general can change in the short term?
The key here is it's not just about noticing mind wandering, because often when we notice things that we don't like, our habitual reaction is to either, try to fight them or resist them or change them some way. But if you look at the neuroscience perspective, habits form through a process called reinforcement learning. And that's also the way that we can help break habits. And so mindfulness really helps to update what's called the reward value in our brain. If something's rewarding, we're going to keep doing it. If it's not, we're going to stop doing it. So for example, we've done studies with people, who want to quit smoking. We have them pay attention as they smoke so they can see that smoking does not feel or taste or smell very good. Same with overeating. When people overeat and we have them pay attention, they directly experience how it's not rewarding. And even with worry, we can help people experience how worrying just makes them more anxious. And this awareness changes this reward value in the brain so that they become disenchanted with it. And this is really the key modality mechanistically that we found it drives behavior change. So really, it's important to focus on these mechanisms, and the mechanism here is bringing that awareness in to change that reward value and help people become less excited to get stuck in that loop. And that really seems to be a key for helping people change unhealthy habits, but also foster healthy habits. So, for example, the more somebody sees how rewarding it sees and feels how rewarding it is to be kind, the more likely they are to get stuck in a good habit loop of kindness.
You often say get curious beats try harder. What at the circuit level makes curiosity a more reliable lever for behavior change than brute self-control?
Well, from a neuroscience perspective, self-control is more myth than muscle. So there's really no clear neural mechanism for how willpower actually powers the brain. So it may be more correlation than causation, and also an opportunity for people to judge themselves and beat themselves up for when their willpower fails. If you look at the number of studies that have been done on what's called ego depletion at this point, and if you look at them net, half of them come out positive and half of them come out negative, suggesting that this is just chance and this is correlation. If you look at the more consistent studies, they really all come down to reinforcement learning, this reward-based learning that I just mentioned. And so the key here is that curiosity really helps people see very clearly how rewarding a behavior is. And if it's not rewarding, they become disenchanted and are more likely to let go of it. And if that behavior is rewarding, like kindness or curiosity itself, they're more likely to foster it as its own new habit because it's rewarding. And, just pragmatically, if you look at this in real world, I do this with my patients all the time. If somebody's stuck in a worry loop, I have them compare what it feels like to worry to what it feels like to be curious. So if they feel anxious, then that drives worrying. They can then compare feeling anxious to getting curious about what that feeling feels like. And what they notice is, first off, that curiosity feels better than worrying. And second, that worrying drives more anxiety. But third, curiosity helps them lean into and turn toward their experience of anxiety and be with it. And they learn distress tolerance skills that way. And that's a clear winner, both in terms of reward value, but also in long-term benefit because curiosity is always available.
Do you ever struggle with having, I'm not sure, are these patients that you're speaking about that you've, but do you ever struggle with getting them to do it? Because I'm trying to put myself in those shoes, and when I'm anxious, I don't want to hear from anyone, oh, maybe you should stop and think. Like, well, when I'm anxious, I just like I kind of push everything out of the way, and I guess it's kind of like fascinating that you can get these your patients to commit to stopping in that moment and just like thinking about it. I'm wondering if you struggle with that.
Well, we can even explore this together. I think you're bringing up a good point. This isn't about getting somebody to stop and think. So if somebody's anxious, I'll give you an example of something that just happened to me just relatively recently. I was flying from Boston to Los Angeles, and there was a young woman that was sitting next to me on the plane. And when we took off from Boston, she looked pretty nervous, and she put on the seat back meditation and listened to it for a little while and seemed to calm down a bit. And the rest of the flight was pretty uneventful until we started descending into LA. And we're just about to land. The plane was slowing down. We were going through the cloud cover. Couldn't really see anything. And suddenly the plane just angles almost straight up and just takes off. And she freaks out. She crosses herself, starts crying, grabs her seat, and just turns to me and says, "I'm really afraid right now." And what I did in that moment was I taught her this practice called 5-finger breathing. I have a YouTube video on that, on how that helps people ground themselves. And the key there was that, when somebody's panicking or really anxious, their prefrontal cortex is offline. They can't really think about anything. I don't know if that's what you were hinting at. Here, it starts with helping somebody ground themselves, right? So their prefrontal cortex can come back online. And only then, once they learn some of these grounding practices, can they start to develop this habit of being curious. And what gets people to actually buy into being curious is that worry is really uncomfortable. And so there's that enough of a pain point for that worry to help them say, okay, I want to try something different. I've been worrying. The worry doesn't help. What else can I do? But it's not just like, here's this thing and suddenly people are going to jump on it and say this is great. In fact, we've just developed a program, a new clinical program that we just launched called Going Beyond Anxiety. And what we do in that program is we provide this, what we call a fundamentals course where people can learn, first, that anxiety can be driven like a habit. So a lot of people don't know that. And so that's one of the first things I tell my patients in my clinic, and I teach them how anxiety can be driven like a habit. That in itself is really helpful for a lot of people because our brains don't like uncertainty, and people who are anxious don't know how their anxiety is driven and how to work with it, So that's the first step. And then we can walk them through how to work with your anxiety. But importantly, we can start to build in tools like generative AI that can be teaching assistants to help them really understand the concepts. And what we found is pretty remarkable, where when people are encouraged in a conversational way, walk through like why to do something like this, it's actually tremendously helpful for them to make sure that they actually understand the concept, but also learn how to use it in their real life.
If anxiety is learned and reinforced like other habits, what's the first practical step someone can take in the wild, mid-spiral, to interrupt that loop?
The first step is to do a grounding practice. So whether, there are a number of practices that we offer, for example, 5-finger breathing, there's a 5-4-3-2-1 practice. It's a grounding practice, number of ways that people can ground themselves. And then we have them start to map out this habit loop. So it gives them something very concrete, very simple to do, where they can start to learn how their brain works. Once they learn how their brain works, then they can start to apply some of these practices for developing disenchantment around anxiety, where they, start to ask this question, like, what do I get from worrying? And what my patients routinely come back with is, wow, I realize I don't get anything from worrying except I get more anxious. And that helps them become disenchanted with the worrying. Often people are very stuck in this worrying process and they think that, the worrying is actually helping them somehow. we help them see very, very clearly that the worrying actually makes things worse. Plenty of data on it, but people really need to learn this in their own life. And then importantly, we teach them what I call the bigger, better offer, where they can start to learn that curiosity is really a superpower to help them be with their feelings of anxiety instead of worrying or needing to run away from them or distract themselves.
I'm remembering, like, I've done therapy myself, and I like the things you're saying, like, it's like I'm hearing it from just one person. Sometimes sounds like, oh, maybe this is not true, but hearing it again, like, it like reinforces everything in my mind. It's just cool. But um, what result from your randomized or real world trials most surprised you? Either because the effect size was bigger than expected or because it failed to replicate lab findings?
I would say we've had several very surprising results. The biggest surprise that we had was in our randomized controlled trial of people with generalized anxiety disorder. And in that study, we wanted it to be a real world pragmatic study. So we randomized people to get usual clinical care where they could get therapy or medications or both. And they could also, one arm would get randomized to get our digital therapeutic for anxiety. And what we found there was a 67% reduction in anxiety within 2 months of just adding in this digital therapeutic that taught them how anxiety habits form and how to work with them. This was compared to only 14% in the usual care group. We also got a 63% remission rate, I believe 63 or 64% versus 3% in the control group. We did not expect the findings to be as strong as they were. But we replicated that study with another study that was similar in people who had worried that was affecting their sleep and saw large reductions in anxiety there. We did a study of physicians who were anxious and got a 57% reduction in anxiety. So it seems that those findings, while the effect sizes seem pretty large, the hallmark of science is replication. And I would say when we look back on it, targeting the mechanism itself seems to be, that's our hypothesis as to why the effects were so strong. If you can really get at a mechanism, and target the mechanism, then you're more likely to get a significant result.
When should an app be the frontline treatment versus a supplement to therapy or meds? And what thresholds, so symptom, severity, risk, comorbidity, tip the balance?
I think that's a great question, and I think that's an individual that I don't have a blanket answer for that. I would be very careful about having an app be a first-line treatment, especially if it doesn't have really solid clinical evidence behind it. We've actually moved away from using just these generic apps where somebody's getting static delivery of content. As an example, in our Going Beyond Anxiety program, we have a more personalized approach where we can have monitoring built in, where humans are in the loop. Whether it's in we have a program that's immersion where people actually get group-based medical visits, but also even our core program where people are doing a self-paced program. We can monitor them carefully and make sure that we adjust accordingly, and then intervene as necessary if somebody's really struggling. And I think ultimately that's a much safer, more personalized, and possibly even a better way to approach it.
In your work on overeating, what's one misconception about hunger or cravings that most reliably derails people, and how do you reframe it?
The biggest misperception that I've seen both clinically and in our programs is that people actually lose the ability to tell the difference between physiologic hunger and emotional hunger. These are described as homeostatic hunger, where there's true physiologic hunger, and hedonic hunger, which is basically eating due to emotional cues. And people tend to, when the more somebody eats when they're not actually hungry, the harder it is to tell when they're actually hungry. So what I do there is help people start to relearn what it feels like to actually have physical hunger, and then also differentiate that from emotional hunger so they can learn to eat when their body needs food and not eat as a way to numb themselves from their negative emotions.
Like specifically, is there like a 1-minute test that you help that you propose to your patients to help distinguish psychological hunger from craving?
The first thing we do is have them first check to see how long ago they ate. So if somebody ate a meal 5 minutes ago and now they're wanting to eat again, the likelihood, if they've gotten enough calories, the likelihood that they're hungry is pretty low. We can also then titrate a checklist of things because there's overlap between physiologic hunger and other types of emotional hunger. So, for example, difficulty concentrating could mean both physiological hunger, but it could also mean stress. And so what we can do is have people go through a checklist of different things to see what the likelihood is that it's more driven by actual homeostatic hunger versus the likelihood that it's driven by hedonic hunger. And we can weight those factors based on, how recently somebody ate and things like that.
As AI enters mental health tools, what are the top two guardrails you consider non-negotiable to protect users while still allowing personalization and experimentation?
Well, the first one is that there really for anything mental health related, there should be a human in the loop. So whether it's having a first layer of careful safety guardrails that are being monitored, which can also be monitored by a generative, by a generative AI model, right? But always it needs to ultimately be kicked up to a human who's monitoring those. So they can flag things that are suspicious or concerning. Human can review those and then intervene as necessary. So I think that's one critical piece. The other is that the guardrails for mental health are, this might sound very basic, but we should not be using out of the box chatbots, that are trained on the entirety of the internet for mental health. We've seen how these go very poorly and even deadly in some cases. A lot of the models have been accidentally trained through reinforcement learning through human feedback or with RLHF, reinforcement learning with human feedback, to become sycophantic, where they'll please somebody. And certainly we need to help normalize behavior and certainly affirm people's experience. But that real therapy is about helping to challenge somebody so that they grow and help them not get stuck in certain worldviews that might not be helpful for them or others as well. So here, the second non-negotiable is that these models really need to be trained on and limited in scope to actual evidence-based treatments and really guardrailed in that way.
Do you imagine any circumstances where it can be fully automated by AI?
Well, I could see down the road, possibly. And it's really hard. I say that with a pause because we really don't know we've seen things go wrong. And we don't know at what level somebody could fully automate, mental health support. So I think that's probably years down the road. I wouldn't say that's never. And some people are more optimistic and saying, "Oh, we're already doing that." And I'd say I wouldn't trust something like that. But I would say the more we learn and the more we can get large data sets where there are humans in the loop that are, and doing the studies showing that these things are safe and that they're staying therapeutically in line with the mechanisms and the evidence-based treatments that they're delivering, the more likely we are to be able to not have to monitor them as much. I'm not sure that that's even a necessary thing for something to be fully automated, because here we can automate the monitoring processes so that they can have really good sensitivity and specificity. And if that's the case, we don't need that many humans in the loop. But here, the nuance is for a human experience is so vast. I don't see a benefit to fully automating anything, especially if we can really dial in the specificity and sensitivity, so not that many humans would need to monitor. So just as a reminder, all of these current models, these LLMs, they're doing is predicting the next character in a sequence of characters, right? That's never going to be the same as human experience. And so in that sense, I'm not sure that we could, I mean, you could automate things to look very, very, very human-like, but with these current crops of LLMs, it is by definition not human, and it's only mimicking human experience. But the just mimicking an output doesn't mean that it's the guts are the same.
Your TED Talk has reached a massive audience. What's one thing you'd revise today? Either a caveat you'd add or a nuance you wish had landed better.
It's a good question. I haven't really gone back and analyzed it, and last time I heard it, it had reached about 20 million people, and most of the feedback I've gotten from people is that it was helpful. I get random emails, not infrequently, about somebody saying they watched my TED Talk and then quit some habit that they'd had for 20 years. So in that sense, I'm not sure what I would do differently. But there's always room for improvement. So I'm just not sure how to answer that.
Okay. If you could implement one policy or reimbursement change tomorrow to bring mindfulness-based treatments into mainstream care, what would it be, and how would you measure success in 5 years?
Well, success, I generally, as a clinician, measure success by looking at clinical outcomes. And so success would still be measured by those clinical outcomes. If we implemented mindfulness therapeutics, I'd want to see a metric change with regard to real world clinical outcomes.
And what's like the single best 5 year metric? So like readmissions, PMPM costs to prove it worked.
I don't think there's a single best metric. I think it depends on what metric you're interested in. So, individuals that have anxiety, for example, aren't as interested in a society level change in cost. And especially in the US, we're seeing costs going up every year by double digits. So, they talk about rating in cost, but something increases in cost all the time. So I think that's hard to actually measure in terms of a real metric, because that's a constantly changing metric. Here, I would say looking at whatever the condition is, looking at the gold standard markers or clinical markers for that condition. So, for example, with anxiety, we look at the Generalized Anxiety Disorder 7 measure. It's a clinically validated and scientifically validated measure. It's also relatively low burden for patients and has some face validity when you look at the questions.
To end off, we always ask this question to all of our interviewees, and it's how do you define success both personally and professionally?
Well, professional success, I look at it really as, are my patients benefiting? Are the studies that we're doing and the therapeutics we're developing, are they reaching people, and are those people showing clinical benefit over time? So, for example, we just looked at our first metrics with this Going Beyond Anxiety program that we've been developing, and we found that 71% of people showed an improvement across every. We're not cherry picking our data, and we're seeing clinically significant reductions within a month. So that's professional success. Is can I develop a program that has real world benefits? But also that ties very closely to personal success, because I have not found anything yet to be more satisfying than helping people.